Good morning. I'm Emery Brown. I'm at Massachusetts General Hospital and Harvard Medical School, as well as Massachusetts Institute of Technology. And today I'm going to talk about multimodal general anesthesia theory and practice. So what I'll do quickly is review the EEG signatures and mechanisms of action of the commonly used anesthetics. And then I'll give you a definition of this new paradigm for multimodal general anesthesia. And then I will illustrate the paradigm through a series of cases. The only conflict of interest which I should mention is that some of the work that we've done on EEG analyses has been licensed to Massimo, and I'm also part of a startup company that's working on physiological control. The company is Pascal. Right. So what is general anesthesia? It's a drug-induced reversible state that consists of antinociception, unconsciousness, amnesia, akinesia, and stability and control of the physiological systems. It's stated that how general anesthesia works is a mystery, that nothing could be further from the truth. The anesthetics generate very powerful oscillations which impede the ability of the various parts of the brain to communicate. One way to easily see this is if you look at the EEG like this, you can see these are EEG signatures of several of the commonly used anesthetics, propofol, sevoflurane, ketamine, and dexmedetomidine. However, if you look at their spectrograms, you can see that they have very distinct features which are very easy to recognize. And each anesthetic has a signature which is related to its mechanism of action. So we're going to use that as we think through monitoring patients under general anesthesia. But before I go into that, I want to just explain one very important circuit, which I would consider to be the most important circuit used in anesthesia today. It's called the nociceptive medullary autonomic circuit, and it's the primary mechanism we use to infer anesthetic state. So if a surgeon makes a cut here, in other words, why is it that we can use heart rate and blood pressure to detect as a way to infer a change in anesthetic state? So if you make a cut here, like free nerve endings, like when the surgeon's doing surgery, you can actually see that this information is transmitted through the dorsal root ganglion, through the anterior lateral fasciculus, and we usually think of it going to the thalamus and cortex, but actually it stops off in the brainstem at the nucleus retractus solitarius. This system talks to the parasympathetic system, nucleus ambiguous, which actually pulls away parasympathetic innervation to the heart, and then it also goes to the rostral ventrolateral medulla and the caudal ventrolateral medulla, and these nuclei communicate with the sympathetic system, so we get increased inotropy, increased chronotropy, and we see the blood pressure, we see the vessels constrict and the blood pressure go up. So this is part of the flight or fight response, and this is the reason that we can use this circuit under anesthesia to track nociception. Let me show you a case. So this is a woman who's 68 years old. She's having a mastectomy. She's on 1.3% sevoflurane. Her vital signs are quite stable, and the anesthesiologist is not using the EEG to track the patient. I was just recording the EEG at the same time. Vital signs are stable. Blood pressure is 128 over about 60. Heart rate is 52. Saturation is fine. Temperature is a little chilly, but nothing out of the ordinary. The key thing I want to point out to you here is that if you look at the EEG, the person's in burst suppression. It's a very deep state of anesthesia, and the only thing that would be deeper is if she were flatline. But beyond being in burst suppression, the monitor here keeps track of how long she's been in burst suppression. What you can see is the blue line under the bottom here. She's been in burst suppression for at least about 50 minutes or so. And there's controversy now as to whether burst suppression is associated with, poor cognitive outcomes like brain dysfunction. It turns out that, that's just being debated, but the key thing is it's a deeper state of anesthesia than she needs to be. The reason she's in this state is that my colleague is not using the EEG to dose her anesthetics. So let's talk about multimodal general anesthesia. So the current strategy used for most anesthetics is to use balance techniques. So we use a combination of drugs to achieve the state of unconsciousness, antinociception, amnesia, immobility, and hemodynamic stability. So under multimodal general anesthesia, the way this works is we maximize antinociception by using multiple drugs to target the nociceptive pathways. We take advantage of the fact that these drugs also decrease arousal. And what that means is we can adjust the dose of the hypnotic, the propofol, the sevoflurane accordingly. To do this, you have to monitor arousal, which we'll use with the EEG, and we're going to use the physiologic responses to monitor antinociception. And ideally, you should use a multimodal strategy postoperatively. So here's a case, a 48-year-old woman who's having an examination under anesthesia, laparoscopic hysterectomy, salpingo-oropharyngeal cystoscopy. She's about 160 centimeters. She weighs about 65 kilograms. So what I used was a combination of drugs here for anti-nociception. So opioid, remifentanil, ketamine, NMDA antagonist, and dexmedetomidine alpha-2 agonist. And I was able to run propofol at 70 mics per kilo per minute to keep her unconscious. Muscle relaxation was assist after curing, and postoperatively we gave her acetaminophen for postoperative pain. So her vital signs are quite stable, as you can see. And you can see she's in a very nice stable pattern of alpha oscillation and slow oscillation, which you can see very well here in the spectrogram, consistent with the idea that she's appropriately unconscious, even though the level of propofol she's getting is only 70 mics per kilo per minute. Her vital signs were quite stable during the case, and she woke up quite comfortably with the anesthetic regimen that we were using. Here's another case, a 77-year-old woman who has a history of end-stage renal disease. She had a kidney transplant with, but now she's had a kidney transplant. Now she has bladder cancer. So they're going to actually take out both of her native kidneys, resect her bladder, and also rebuild her bladder with an ileal loop. She's about 155 centimeters. She's about 81 kilograms. And so for this regimen here, I use dexmedetomidine and lidocaine as my anti-nociceptive agents. And if you look here, the propofol is at 20 mics per kilo per minute. I mean, barely a sedative dose. She was getting rocuronium as a muscle relaxant, and pain was controlled with a rectus sheath block. And you can see that even when I had her in this very low doses of propofol, she's in burst suppression. You can see it here on the EEG and also here in the spectrogram. So it shows you that we have, because she's older, she does not need as much anesthesia and actually to produce unconsciousness. And moreover, we're getting the effects of the anti-nociceptive agents, which are helping the propofol keep her in a state of unconsciousness. And she needs extremely little amounts of propofol to do that. That's what this case illustrates. I'll show you one final case. This is a woman who's over 89 years old. In the United States, when someone's over 89 years of age, you can't say their actual age in a presentation. She has a history of diabetes, high blood pressure, and she's having a laparoscopic right colectomy. She's about 153 centimeters, and she weighs about 57 kilograms. So my anti-nociceptive regimen here was dexmedetomidine, remifentanil, and lidocaine. We kept her unconscious with propofol, again, an infusion rate, which was very, very low. And she got oral acetaminophen and IV hydromorphone for her postoperative medications. And here she is. You can see her vital signs are quite stable. Her EEG shows primarily slow oscillation, something which is quite typical of older patients because the alpha oscillations tend to be, much weaker as we get older. But she's appropriately unconscious. Her vital signs are stable, so I have no question that I have adequate nociceptive control as well as the fact that she's unconscious. So how is this working? So we can look at it this way. These are the nociceptive circuits, primarily the opioids, ketamine and magnesium, which are NMDA. The opioids work on opioid receptors. And then the dexmedetomidine works through alpha-adrenergic receptors, and these are the circuits. And we can think of lidocaine as along with anti-inflammatory drugs, which help block inflammation and reduce the nociceptive response. So just to blow this up, so the drugs act on the nociceptive system, but if you look at ketamine in general, ketamine here works to block this pathway here coming into the spinal cord. The first synapse from the dorsal root ganglion into the spinal cord is glutamatergic, and that's a very important nociceptive pathway. But it also acts here on these projections from the parabrachial nucleus, the medial pontine reticular formation, into the thalamus and to the basal forebrain and onto cortex to reduce arousal. So what this means is the amount of propofol you need to keep someone unconscious is substantially reduced. And so when you use multiple drugs in combination, this is the effect that you achieve. So what I've just shown you is that understanding the EEG signatures and mechanism of action of the commonly used anesthetics provides a principal strategy for monitoring level of unconsciousness. The new paradigm for multimodal general anesthesia makes explicit the control of nociception and unconscious and the impact the interactions among them have in creating the state of general anesthesia. It requires monitoring unconsciousness and anti-nociception to guide anesthetic dosing. And this can hasten the emergence and can help minimize the postoperative cognitive effects that we see commonly with GABAergic anesthetics. And ideally, we should use an explicit paradigm the same way for postoperative management of pain following anesthesia. Thank you very much for your attention.